Yes, Kiran, you can start.
Yes, sir. Good morning. Today I'll be talking about fluid responsiveness, and my moderator is Dr. Srinivas Samadhan, sir. Unable to change the slide, sir.
Just did you check it before?
Yes, sir. First I
Just go on to slideshow and then or share it once again. Exit, close it, share it once again.
Good morning. I'll be talking about fluid responsiveness today, and my moderator is Dr. Srinivas Samadhan, sir. So the fluid responsiveness, fluid administration is the first step in any patient with acute circulatory failure, and we need to know which patients require fluid responsiveness, like to assess the fluid responsiveness. We don't assess the fluid responsiveness in all the patients, like in patients who have come to the ER with obvious hypovolemia, obvious hemorrhage, had multiple episodes of loose stools, and patients with burns who are obviously hypovolemic. You don't assess fluid responsiveness that time. You have to give fluid resuscitation that time. So inadequately corrected hypovolemia results in tissue hypoperfusion and organ damage, and volume overload in other situation. If suppose you give you think the patient is fluid responsiveness, has fluid responsiveness without even assessing, it can lead to volume overload, and it can also increase the morbidity and increase the complications and mortality. So definition of fluid responsiveness is the ability of the left ventricle to increase the stroke volume by 10 to 15% in response to fluid bolus of we take it as 500 ml of crystalloids over 10 to 15 minutes. This is known as fluid responsiveness or preload responsiveness. So the basic physiology of fluid responsiveness is that suppose with what intention we are giving the fluid bolus is that we have to see for the increase in the stroke volume, and that should ultimately increase the cardiac output to have adequate tissue perfusion for the patient. So if ultimately if the fluid which we have given, if it doesn't increase the stroke volume or has not caused adequate tissue perfusion, then it doesn't serve the purpose. So main thing is, if you give fluid, our aim is to increase the stroke volume and increase the tissue perfusion. So cardiac output can be measured with the help of stroke volume and heart rate. And stroke volume, it dependent on the preload, afterload, and contractility of the heart. So this is the Frank-Starling curve. It shows the relationship between the cardiac preload and the stroke volume. So the curve depends on the ventricular systolic functions. So here you can see on the top part, you can see the normal ventricular systolic function, and the down part, you can see the poor ventricular function, systolic function. So suppose you give fluid for patients with both the category, patients with normal ventricular systolic function or poor ventricular systolic function. You have given a 500 ml fluid challenge, and you see how much stroke volume, what is the response of the patient in relation to the stroke volume. Suppose in patient with poor ventricular function, and you are given the preload challenge, if it is falling on the flat portion of the Frank-Starling curve, then you can see here there is no much increase in the stroke volume, and it can cause only harm for the patient. Because I've already told, our aim is to increase the stroke volume and increase tissue perfusion. So if with the patient with normal ventricular function and you have given preload challenge, and if it's falling on the steep part of the Frank-Starling curve, it causes significant response and increase in the stroke volume. So due to the variability in the slopes of the Frank-Starling curve, a single marker of cardiac preload doesn't indicate the preload responsiveness. Suppose we get a value of 8, you can't tell if the preload of 8 is equal to preload responsive, unless if it is on the extreme values. If it is very low or very high, you can think of then you can at least interpret it as responder or not responder. But in between value, you can't tell as a single marker, single value, you can't tell it is a preload responsive or not. So the fluid challenge is necessary in patients who have after initial resuscitation, then to determine whether patient can take some more fluid or not. That time you need to do fluid responsiveness assessment. As per this is a paper by Dr. Paul E. Marek. He had written the fluid responsiveness and 6 guiding principles for fluid resuscitation. He had told that fluid administration will increase the stroke volume only if it increases the stroke volume. If it will increase the stressed volume and thereby increasing the mean systemic filling pressure. Mean systemic filling pressure is the mean pressure in the systemic vascular system with no flow state. That is usually present in the splanchnic vessels and other systemic circulation. If the fluid which we give is going to increase the mean systemic filling pressure more than the CVP, that gradient should be maintained. The mean systemic filling pressure minus CVP, that gradient should be maintained to determine the venous return of the ventricles. And he told that clinical signs, just using only clinical signs or CVP or ultrasonography alone cannot determine the fluid responsiveness. And the PLR and fluid challenge coupled with the real-time stroke volume monitoring is accurate method for determining the fluid responsiveness. And suppose you have given fluid challenge, it is more and it is short-lived. If you give a fluid challenge and you see if the patient is fluid responsive, and after 30 minutes you have to do it again and check. It doesn't mean if you do now it lasts for many hours. And fluid responsiveness does not equate to the need of fluid bolus. There are many patients or normal people who are fluid responsive. That doesn't mean everyone requires fluid boluses. Only in patients who has decreased tissue perfusion or acute circulatory failure, we need to give fluid challenge. And high CVP is a major factor compromising the organ perfusion. It's shown that high CVP causes increased renal pressure, causing decrease in renal blood flow and can cause AK. That also he has demonstrated. And I told you previously when to assess fluid responsiveness, not in patients who are obvious hypovolemic or ongoing hemorrhage. You need to do once you have adequately fluid resuscitated to know if the patient can take some more fluid or better to start vasopressors. In that stage, you can do fluid challenge and see. And this is a classification given by Cavallaros. He divided into Group A, Group B, and Group C. Group A is mechanical ventilator induced cyclical changes in stroke volume dependent parameters. That is stroke volume variation, pulse pressure variation, or aortic blood flow. Whereas Group B is mechanical ventilator induced cyclical changes in non-stroke volume dependent parameters. That is vena cava diameter. So here the stroke volume doesn't come into picture. And group C is preload redistribution maneuver. That is the PLR, passive leg raising test. So the methods for assessing fluid responsiveness, we use either static or dynamic parameters. Static parameter with the help of volume, the global end diastolic volume or right and left end diastolic volume in separate. We can use to measure the preload, and pressure, with the help of pressure we can assess the fluid responsiveness, that is CVP or pulmonary occlusion pressure, or with the help of IVC diameter. Whereas dynamic parameters, it uses cyclic variation in the stroke volume in relation to the heart-lung interaction. So based on the stroke volume parameter, we use pulse pressure variation, stroke volume variation, or non-stroke volume related measurement, that is IVC distensibility, all those. And other tests are PLR, end expiratory occlusion test, tidal volume challenge test. I will be telling each one in detail. The first is the static indices. The marker of the preload has been proposed to predict the fluid responsiveness, but numerous studies have shown that, as I already told, a single cardiac preload marker doesn't predict the fluid responsiveness. One single value can't predict the fluid responsiveness. It can tell the preload if what preload we are given is okay, but it doesn't predict if that preload which we are given can increase the stroke volume or not. That requires dynamic parameters. So first, coming to the static parameter, that is traditionally used CVP. CVP is measured using the central venous catheter, which is placed in the junction. The tip is placed between the right atrium and the SVC, and help to measure the blood returning to the heart. And it has been traditionally used to guide the fluids. The CVP is a good approximation of right atrial pressure, and is a major determinant of the right ventricular filling. So CVP is a good indicator of RV preload, and furthermore, this RV preload is the one which predicts the LV filling as well. So CVP is assumed to be indirect measurement of LV preload, that is LV end diastolic volume. It has been measured at the end of the, it is best and optimal to measure at the end of diastole and end of expiration. So given CVP value cannot determine whether the patient is fluid responsive or not. If one value of 8 or 10 can't tell if patient is fluid responsive or not. Only extreme value can help us in a bit to guide the fluid administration. Changes in the CVP during fluid administration and increased cardiac output indicates fluid responsiveness. There are many assumptions with when using CVPs. That is, first assumption is that the left heart is equal to the right heart, because we are placing the catheter in the right heart, and we are assuming that, and we are trying to calculate the left ventricular end diastolic volume. We are measuring central venous pressure, and second assumption is that pressure is equal to volume, and the third assumption is that there is in between no AV valvular pathology, that nothing is there, that we are assuming. And we are assuming that the CVP is equal to the right atrial pressure, which is equal to right ventricular end diastolic pressure, and that is equal to left ventricular end diastolic volume. But these many assumptions are there, but in critical ill patients, these assumptions may be wrong. So the factors which increase and decreases the CVP, there are many other external factors also contributing to increase and decrease in CVP. like patient with raised CVP may be due to hypervolemia. Other causes can be patient with the tension pneumothorax, cardiac tamponade, or valvular heart disease can also give wrong values. So a study was done by meta-analysis was presented by Polymeric. He compiled 43 studies, included 1800 patients, and showed the area under the curve was only 0.5, which was like this is the area under curve for predicting the fluid responsiveness with use of CVP. So he concluded that there was no data in support of widespread practice for the use of CVP to guide the fluid therapy. And next one is the PAOP, that is pulmonary artery occlusion pressure, which corresponds to the end-diastolic pressure of the LV. The pulmonary artery occlusion pressure can be subjected to many variables, like if the patient has poor LV compliance or pericarditis, patient has mitral stenosis, increased intrathoracic pressure. All these can cause abnormal values, like false positive or false negative values. So a study done by Michard et al. Which showed that measured PAOP before and after giving fluid in two categories of the patient, that is responders and non-responders, showed that non-significant evidence of measurement of PAOP in 7 out of 9 studies. So PAOP also PAOP measurement for assessing the fluid responsiveness also is discouraged. Next, coming to the IVC diameter, it is thought to be a reflection of the right atrial pressure. It is more likely demonstrates the relationship between the right atrial pressure and intra-abdominal pressure. It is measured 1 to 2 centimeter caudal to the caval atrial junction while avoiding the hepatic vein. The accuracy depends on the operator, the images which has been acquired, and the analysis by the operator. So multiple erroneous values also we can get. Next, coming to the global end-diastolic volume, this is done by using PICO or volume view. It uses transpulmonary thermodilution technique with the help of central venous catheter and thermodilution tipped arterial catheter. We calculate the global end-diastolic volume. The monitor shows the global end-diastolic volume and global end-diastolic volume index. It basically tells the volume in the 4 chambers of the heart, but we cannot tell if the after giving fluid whether the patient is fluid responsive or not. Based on this is all static parameters. It tells how much volume is there in the chamber, but volume status it tells, but not the volume responsiveness or fluid responsiveness. So again, the Frank-Starling curve. If the patient falls in the flat portion or the flat portion of the Frank-Starling curve, we can tell patient is not fluid responsive. Or if the patient is falling on the steep part, we can tell patient is fluid responsive. And a given value, as I previously also told, a particular value of the preload cannot tell if the patient is preload responsiveness or not. So what we need is a dynamic parameter. Even Surveying Sepsis 2021 guidelines also have mentioned that dynamic parameters is better than the static parameters for predicting the fluid responsiveness. Even ESICM has told in acute circulatory dysfunction, we recommend using dynamic over the static variables to predict the fluid responsiveness. So coming to the dynamic parameters, we see the changes in preload induced by the intrathoracic pressure induced by mechanical ventilator patient to assess the fluid responsiveness. the following parameters are there, like many measurements we can do to assess the dynamic parameters, like pulse pressure variation, stroke volume variation, tidal volume challenge test, index pressure occlusion test. So all this will require principle of heart-lung interaction. So these are the cyclical changes in the stroke volume in relation to the relationship to the respiratory changes. That is respiratory changes uh, due to increased or decreased intrathoracic pressure, how that influences the stroke volume. That is the heart-lung interaction. So we see the in mechanical ventilator patients, initially during inspiration there is raised in intrathoracic pressure, which causes decrease in the venous return, causing decreased RV preload, and this decreased RV preload causes low stroke volume. Right ventricular stroke volume is decreased at the end of inspiration. But with the because of increased transpulmonary pressure, the RV afterload is increased. So both RV preload decrease and increased RV afterload can both cause decreased RV stroke volume at the end of inspiration. Whereas because of high intrathoracic pressure, the transpulmonary pressure is increased and causes decrease in LV afterload and increase in LV preload, thereby causing increased LV stroke volume. So here you can see at the end of inspiration, we can see increase in LV stroke volume and decrease in RV stroke volume. This increase in LV stroke volume, we can see here the pulse pressure variation, the upstroke is higher than what is shown here. The pulse pressure variation at the expiration is low because of this, because the increase in stroke volume in the left side. So this is the expiration. During the expiration, the decrease in the RV stroke volume causes low LV preload, which causes decrease in the LV stroke volume. At end of expiration, there is decrease in the LV stroke volume. So the pulse pressure variation we calculate, we measure using the arterial waveform, and it shows the mechanical ventilator induced cyclical changes in the left ventricular stroke volume. The pulse pressure variation is directly proportional to the stroke volume and inversely related to the arterial compliance. We assume that the arterial compliance does not change with the respiratory cycle, and the changes in the pulse pressure should reflect the respiratory change in the LV stroke volume. So here I showed you previously, this is the upstroke, which corresponds to the raised intrathoracic pressure, and at the end of inspiration, the PP we calculate the PP max, whereas end of expiration we calculate the PP minimum. So pulse pressure variation is calculated by PP max minus PP minimum by PP mean into 100. Michard et al. Showed that a cutoff value of more than 13 was able to discriminate the fluid responsiveness from non-responder with a sensitivity of 95% and specificity of around 96%. So the extreme values, like if the PPV is more than 13 or less than 5, less than 5 means patient can be told that patient is non-fluid responder, or more than 13 we can tell fluid responder. The intermediate values like 8 to 13, that is known as the gray zone. So the paper was there on the clinical relevance of PPV for predicting fluid responsiveness in mechanical ventilator patient, the gray zone approach. This is the gray zone approach was introduced based on the overlap of the PP values between the responder and non-responder. That is the intermediate value, which I told you. other than the extreme value, the intermediate value is a gray zone value. The low cutoff value exclude the fluid responsiveness in 90% of the patient, whereas high cutoff value predicts the fluid responsiveness in 90% of the patients. Biasis et al. Also did a study on PPV using PPV for fluid responsiveness, and he has also told that values between 4 to 17, which occurred in 62% of the patients in his in 9 French ICUs which he had studied. So most of the patients fall in this gray zone only, and it is little difficult to estimate if the patient falls on the gray zone. It's difficult to assess for the, you can't tell accurately that patient is fluid responsiveness or not. So there are other external confounding factors which can cause false positive and false negative value to the pulse pressure variation. Those are extreme bradycardia or high patient having high respiratory rate can cause false negative PPV values. If patient has arrhythmias, patient can have high, false positive values. And patients, we have to use tidal volume of more than 8 ml per kg. If you use low tidal volume, can cause false negative values. Or patient with high intra-abdominal pressure due to ascites or pneumoperitoneum can have false positive values. In spontaneous breathing patient can have false positive or false negative values. So many limitations are there for using the pulse pressure variation. There is in spontaneous breathing patients or patient with cardiac arrhythmias, low lung compliance in ARDS patients. So in ICU, if you see, most of the patient will have either one of this. So PPV we can't use accurately in such patients, in ICU patients. Similarly, stroke volume variation. Here we calculate measure the changes in the stroke volume during the respiratory cycle. This also utilizes the heart-lung interaction, and this is the upstroke which shows during inspiration the stroke volume max is calculated and stroke volume minimum is calculated at the end of expiration, and we calculate stroke volume variation by stroke volume SV max minus SV minimum by SV mean. If it is more than 10, it's a sensitive predictor of fluid responsiveness. Next, coming to vena cava dimensions. This also, the IVC or SVC, we can see the changes in the IVC or SVC during the mechanical ventilation. It also helps to predict the preload responsiveness. The mechanical ventilator induced cyclical changes in the vena cava diameter are more pronounced in hypovolemic patients if they are falling on the steep part of the Frank-Starling curve. So in mechanical ventilator patients, we measure the IVC distensibility index, which is the IVC max minus IVC minimum by IVC minimum. If it is more than 18, it has high sensitivity and specificity for fluid responders. In spontaneous breathing patients, we use IVC collapsibility index, and it is done by measuring the IVC max minus IVC minimum by IVC max into 100%. More than 12% is considered to be fluid responsiveness. But there are limitations in measuring IVC as well. It depends on the person, physician to physician, and if you have not kept the probe or if you're not measuring it right, it can give a wrong values, or other values like other confounding factors are like increased intra-abdominal pressure, RV dysfunction, arrhythmias. If you use tidal volume lower than 8 ml, it can give false values. And a study was done which showed low diagnostic sensitivity and specificity in detecting the preload responsiveness with the use of this vena cava diameter. Many confounding factors which can cause inaccuracy of fluid responsiveness, like if you use high PEEP or low tidal volume, patient having increased respiratory efforts, having high respiratory rate, in distress, you can't use this. Patient who have lung hyperinflation due to COPD, or patient having cardiac tamponade or tension pneumothorax, values can be wrong, or patient with pneumoperitoneum, the values will be wrong. Next is stroke superior vena cava respiratory variation. In mechanical ventilator patients, we can measure it using the transesophageal echo. This also, if similar confounding factors are there for this also. If the right ventricular function, if there is right ventricular dysfunction or arrhythmia, if you are using low tidal volume, it gives the wrong values for predicting the fluid responsiveness. Next is the transthoracic echocardiography. We use a triple E approach. We first see the effusion and equality, right and left equality, and efficiency, the systolic function we see. But all these are the static measures. To know the dynamic measure, we use LVOT and VTI. The first we have to use keep the probe in the parasternal long axis and freeze the image, and image is frozen. And during the systole, when the aortic cusps are fully open, the inner edge to inner edge is calculated, that is LVOT, and pulse wave Doppler is recorded at this LVOT, and area under the trace is the VTI. It corresponds to the VTI basically tells the stroke distance or displacement of the RBC during the systole. If the value of VTI is more than 18 to 20%, then it shows the patient is fluid responsive. This algorithm, how we can approach a patient who has come to ER with or to come to ICU. How can you approach if you can give fluids or not? First, you have to see obvious thing, like you do an echo and you see if the patient has kissing ventricles, hyperkinetic LV, and small or collapsible IVC. Then you need to give fluid resuscitation. Once that is done, and you see other values, other things like other limiting condition like arrhythmias, patient having a valvular condition, RV failure, new onset RVMA he has come with, or spontaneous breathing. If none of these are present, then you can use the various measurements which I have told. The PPV you can use, LVOT, VTI you can use, and based on this we can give fluids. If patient has arrhythmias or RVMI, or patient has respiratory distress, we can't use pulse pressure variation and stroke volume variation, all those. So we can use LVOT, VTI along with PLR. I'll discuss PLR in detail. So next is using aortic blood flow. For measuring the aortic blood flow, we need esophageal Doppler. So the variation in the aortic blood flow over the respiratory cycle between its maximum and minimum is calculated. And based on this, we can tell patient is fluid responsive or not. The respiratory variation in the aortic blood flow, if it's more than 18% before the volume expansion, means if the variation is more than 18%, that means we can give fluid. He can be fluid responsive, and the sensitivity is 90% and specificity is 94%. Next is the tidal volume challenge test. As we know, most of the initially whatever I have discussed, PPV, stroke volume variation, all those require tidal volume more than 8 ml per kg of ideal body weight. One study was done by Sheila Micra ma'am. She showed, which showed that lower tidal volume, using lower tidal volume and transiently increasing the tidal volume to 8 ml per kg. Suppose patient has ARDS and you are using lung protective ventilation with low tidal volume. And what we can do is, first we measure the pulse pressure variation at that tidal volume itself. Like if the tidal volume we have initially set at 6 ml per kg, we initially measure the pulse pressure variation at this, and transiently we increase the tidal volume to 8 ml per kg. And we next measure the pulse pressure variation at that increased tidal volume. So if the increase in the pulse pressure variation with a cutoff of more than 3.5 is there, if the initial value was 6 and it has increased to 12 after increasing the tidal volume transiently, this is a transient change of tidal volume we need to do. If increase in ppv is more than 3.5, it predicts the fluid responsiveness with a sensitivity of 94% and specificity of 100%. We can also measure this using stroke volume variation with a cutoff value of 2.5% with high sensitivity and specificity. So as I told you, first we have to, when the patient is having lung protective ventilation with 6 ml per kg, we measure the ppv initially, and we give transient tidal volume challenge, like increase the tidal volume to 8 ml per kg transiently for 1 minute, then measure the ppv and svv, and again decrease the tidal volume to again 6 ml per kg. So the difference between this and this, if it is more than 3.5, then the patient can be fluid responsive. So the limitation of using the tidal volume challenge is patients in spontaneous breathing ventilation, spontaneous breathing, or patient having cardiac arrhythmias, increased intra-abdominal pressure, or patient with low compliance can all give false values. Next, coming to end expiratory occlusion test. For this, the patient has to be on mechanical ventilation, and we have to use a real-time precise cardiac output monitor. Similar to measuring the auto PEEP, we keep a 15-second pause at the end of expiration, and what it does is it helps to prevent the during the next inspiration, as I already told, increased intrathoracic pressure can cause decreased venous return. So by stopping this cycle to happen, by giving a pause, the preload is increased. Increase in cardiac preload and cardiac output is suggestive of preload responsiveness. So the increase in cardiac index of more than 5% during end expiratory occlusion predicted fluid responsiveness with sensitivity of 91% and specificity of 100%. So why we are giving this 15-second pause? Because I already told, from during the inspiration, from inspiration to expiration, in between there is pulmonary transit time. From right ventricular stroke volume has to go reach the left ventricle. So this transit time is there. If we give a pause more than 15 seconds, it allows to increase the preload to be transmitted from the right to the left side. End expiratory occlusion test, the advantage is it can be performed in patients with arrhythmias, low tidal volume, patients with low lung compliance, and it's independent on the PEEP level. So it is performed like this. First, we need to use a precise real-time cardiac output monitor, and we have to perform end expiratory occlusion test similar to intrinsic PEEP. Like you give a 15-second pause, and you see if the, as I told you, increase in cardiac index more than 5%. Then if there is increase in cardiac index, then we can give fluid, patient is fluid responsiveness, has fluid responsiveness, then you can give fluid challenge for this patient. Next is corrected carotid flow time. This uses point of care Doppler ultrasound assessment for the changes in the corrected carotid flow time for the fluid responsiveness. Here we calculate, we measure the carotid flow velocity. This upstroke measures the velocity and this one measures the carotid flow time. This helps to tell whether the patient has fluid responsiveness or not. Has a sensitivity of 70% and specificity of 96%. Next, these all are non-invasive methods. Next is the pleth variability index. This uses the respiratory variation in the pulse oximetry plethysmographic variation waveform. We measure the amplitude. See here we can see the plethysmographic variations as per it is dynamically changing as per the respiratory variations. Here you can see if it's increasing and it's decreasing here. These are the pulse oximetry plethysmography variations. If the delta pulse oximetry plethysmography is more than 15%, it is almost equivalent to PPV of more than 13%. Means you can give means the patient is fluid responsive. It has sensitivity of around 81% and specificity of 100%. Next, we measure the end-tidal carbon dioxide variability in fluid responsiveness. The end-tidal carbon dioxide is a it's basically indirectly tells the cardiac output, and the increase in the cardiac output leads to increase in the pulmonary blood flow. This in turn increase the alveolar perfusion, which can increase or decrease the end-tidal CO2. In patients with cardiogenic shock, sudden onset cardiogenic shock, you can see patient with the low cardiac output, they have decreased pulmonary blood flow and decreased perfusion. So their EtCO2 values also can be on the lower side. So when you combine the EtCO2 variation with the PLR, it has been shown an increase in 2 mmHg of end-tidal carbon dioxide or 5% from baseline has been proposed to indicate the fluid responsiveness. Next is a passive leg raising test. This is a internal preload challenge test where we need not use a external fluid to see if the patient is fluid responsive or not. We can use auto transfusion of the blood from the lower body of approximate 300 ml towards the right heart, which mimics the fluid challenge. It takes the help of heart-lung interaction induced changes which can't be used in, suppose in PPV and SVV and all. I have told that we can't be used in spontaneous breathing, arrhythmias, and low tidal volume. All these things are overcome in this passive leg raising test. We can use in patients with spontaneous breathing or patients with arrhythmias also. And but the thing is, we have to use a real-time cardiac output monitor for accurate measurement of this values. So first, what we need to do is patient will. You have to make sure that the patient is in semi-recommended position at trunk more than 30 or to 45 degree head up, and you need to have use a real-time cardiac output measurement, and we give, with the help of bed adjustment and avoid touching the patient, we give a head down and leg up, and we assess for the cardiac output, changes in the cardiac output. And from this position, again, we shift back the patient to semi-recommended position. Means the patient should return to the baseline. And we should see from between the 1 and 3, when the patient was in the baseline, semi-recommended position, and when we give the head low or the leg up with 45 degree, the changes in the stroke volume or cardiac output, that is due to the auto transfusion. Sudden increase in the stroke volume will be there, And when you get back the patient to the baseline, when you get the patient back to the semi-recumbent position, there is automatic decrease in the increase you have observed will automatically come to the baseline. This predicts the fluid responsiveness of the patient. So then you can give fluid expansion and see if the patient can tolerate more fluids. So advantage of this method is it can be reversible and no fluid infusion needs to be given. It's a very well validated test. It can be used even in patient with spontaneous breathing or patient with cardiac arrhythmias. The limitations are patient with the intra-abdominal pressure, it can give a false reading. And patient where we use compression stockings, it can give false negative values. When we measure real-time cardiac output monitor with the threshold of more than 10%, it has got a very good level of evidence. And by using the VTI at the threshold of more than 10%, this also has a good level of evidence. The limitations for this are patients you can't use in patients with raised intracranial pressure or having intra-abdominal hypertension. So the PLR can be used to guide fluid removal as well. In patients with, first you do a PLR test before starting ultrafiltration, and we can predict the intradialytic hypotension. Secondly, to preload responsiveness. First, before starting of dialysis, if a patient has because of PLR, there is increase in cardiac index by more than 15%. That means it can predict the patient can have intradialytic hypotension. The fluid responsiveness to predict the weaning. Suppose in patients with pre-existing cardiac failure or cardiomyopathy who has been intubated, we can do a PLR and predict if they are in the steep portion of the Frank Starling curve, then they can tolerate weaning better than who are in the flat portion of the Frank Starling curve. So next is if the patient has a negative PLR test before doing a spontaneous breathing trial, it is a predictor of weaning failure, and the patient has high chances of having developing pulmonary edema. It has a good sensitivity of 97% and specificity of 81%. Next, coming to mini fluid challenge test. Here, instead of giving a large volume of fluid, we give 100 ml of crystalloid over 1 minute with concomitant monitoring of the aortic VTI to predict the subsequent fluid responsiveness to large boluses. Suppose after giving the mini fluid challenge, the VTI has increased by 10%. Then it shows the patient can be fluid responsiveness with a sensitivity of 95% with a specificity of 78%. But we need to have a precise and accurate monitor, cardiac output monitoring for knowing this changes in the calculation. And the problem with using mini fluid challenge is that it must be used in caution, as initial bolus of fluid may not predict the response to subsequent bolus due to the curvilinear aspect of the Starling relationship. And the other second limitation is the amount of fluid may be insufficient to elicit the changes in preload and hence cardiac output. So leading to the false negative response. So amount of fluid which we have given maybe is limited, so it may not be enough to elicit the preload change, and it can cause false negative response. Advantages: easy to perform, and it can be used even in arrhythmia patients or patients with low lung compliance. The limitations, as I already told, uh, it requires precise cardiac output monitoring, and patient we are giving a limited fluid challenge. So it may not be enough to predict the correctly estimate the change in the VTA. So criteria of judgment, we use VTA or cardiac output monitor with a threshold of 5 to 10%. It has moderate level of evidence. Next, coming to the dynamic arterial elastance, during resuscitation, along with the increase in cardiac output, sufficient increase in arterial pressure is required to maintain the tissue perfusion. It doesn't, the fluid responsiveness doesn't depend only on the LV stroke volume, it also depends on the arterial pressure. The arterial load is the other factor that determines the mean arterial pressure changes in response to fluid administration. So to know the arterial tone, arterial tone evaluation is done by dynamic arterial elastance, which is defined by ratio of PPV and stroke volume variation. The dynamic arterial elastance describes the dynamic interaction between the changes in the pressure and flow, and dynamically evaluates the change in the arterial load. So in patients with who are after you give fluid challenge, fluid volume challenge, and there is increase in MAP of more than 15%, that means they are MAP responders. The baseline dynamic arterial elastance values greater than 0.89 predicted a mean arterial pressure increase after fluid administration with the sensitivity of 95% and specificity of 100%. In hypotensive patient who are not fluid pressure responder, we have to give vasopressors instead of giving more fluids. Last is the extravascular lung water and PVPI, that's pulmonary vascular pressure index. It is measured using the advanced hemodynamic monitoring. High PVI in extravascular lung water value indicates that patient has lung edema, that is pulmonary edema, and increased PVPA indicates that patient has pulmonary leak. So here we can see the relation between the pulmonary capillary hydrostatic pressure and extravascular lung water. If the patient has normal permeability, giving a large volume expansion like fluid challenge of 500 ml, there is no much increase in the extravascular lung water. Whereas patient with ARDS who has high permeability, giving this much volume, if you are giving this much, suppose you give 500 ml volume, it can cause huge increase in the extravascular lung water and can cause pulmonary edema and cause deleterious effect. So this is algorithmic approach how we can approach a patient with acute circulatory dysfunction. Like if patient has low BP and low cardiac output, first you have to see if the patient has signs of tissue hypoperfusion. If there is obvious tissue hypoperfusion, we give and there is obvious fluid loss, we give fluid resuscitation immediately. Then we have to see, then comes a role of assessment of fluid responsiveness. Then if you have to see if the patient is spontaneous breathing of having cardiac arrhythmias or having low tidal volume. If they have these things, we have to use passive leg raising test or end expiratory occlusion test or mini fluid challenge test. And based on this, we can give fluids. If the patient doesn't have this, patient is mechanically ventilated without cardiac arrhythmias, having a tidal volume of more than 8 ml per kg. If they meet this criteria, then we can use pulse pressure variation, or with pulse pressure PLR, we can use this pulse pressure variation. and even SVC or IVC variability also can be used. And based on this, we can use we can determine whether the patient is fluid responsive or not. Thank you.
Thank you, Kiran. I think it was a comprehensive review of fluid responsiveness, the principles, and the various options available to us. Ghanshyam, you want to add?
I think, Kiran, you have covered almost everything. Just because we are talking about fluid responsiveness, which comes as a part of hemodynamics, just want to add, though your SCVO2 and delta PCO2 don't directly come under fluid responsiveness, but I think that these two parameters also are quite important, especially when we are looking at hemodynamic monitoring of patients who are critically ill with acute circulatory insufficiency. So we also need to know about how to interpret central venous oxygen saturation and the delta PCO2, because both of this can be useful in specific situations. So just know about these two parameters as well.
Okay.
So, I think fluid responsiveness, we have discussed it so many times, and everybody has their own viewpoints about it. And we know that having heard this talk, there are many methods of assessing fluid response. But the point here is the 2 or 3 situations where fluid responsiveness is a major issue, and you need to be absolutely sure that the patient is fluid responsive, where fluid can be harmful, is ARDS, where the PF ratios are less than 100, abdominal compartment syndrome, and in the coagulopathic patient. Now, coagulopathic patient, if you leave them aside, the 2 situations, ARDS and intra-abdominal hypertension, these are 2 conditions where there is no single validated tool for fluid responsiveness, which will tell us that the patient is hypovolemic and you need to give more fluids. Probably the tidal volume challenge test is one method which can be applicable in ARDS patients, but in a patient who has intra-abdominal hypertension, where the intra-abdominal pressure is more than 12, there your CVP, your IVC diameter, IVC collapsibility, IVC distensibility, and all other parameters are abnormally skewed because of the third pressure which is coming. It is not the transmural intracardiac pressure, it's not the intrathoracic pressure, but a third pressure is confounding these measurements. So this is the situation where a combination of methods and sound clinical judgment is probably still needed for us to make a judgment on fluid responsiveness. So that's about the crux of fluid responsiveness. Those of you who have queries or clarifications on this topic, please do post your queries on the WhatsApp group or the channel on which you got the link for this program, and the speaker, the moderator, and the directors of the academic program. We will try to answer these questions to the best of our abilities. Next week, we will talk about cardiorenal syndrome, which is another important aspect closely related to fluid. It is often said that what is good for the heart is not good for the kidneys in terms of diuretics, and what is good for the kidneys is not good for the heart in terms of fluids. So, how do the cardiorenal syndromes behave? What are our methods of approach? Is what we will talk about next week. That will be done by Dr. Smita and will be guided by Dr. Mithilesh. So, we wish Kiran a happy journey on his way to Turkey to present his data on nutrition in shock. We will meet again next week at the same time. Thank you very much. Join us again.
Thank you, sir. Thank you, sir.